Okay. Good evening, everybody. My name's Matthew Brown. I'm the Director of University of Queensland's Diamantina Institute, which is the institute which is running tonight's event. I'd like to start by welcoming you all to our beautiful auditorium and research institute, the Translational Research Institute, and to thank you all for giving up your evening to come and hear about exciting developments in blood cancers. So I thought just a brief background about Diamantina Institute would be helpful. We're a 300 or so scientist research institute that's based here in TRI. We have research programs that work on genomics, which you'll hear a lot about tonight, immunology, and also cancers, particularly skin cancers and, importantly, blood cancers. This series of talks that we're giving, the Your Health Future talks, are a program of talks that we give 3 times a year, which are an attempt by our institute to reach out to interested members of the community and tell you about exciting developments in science and how they're impacting on healthcare in Brisbane and more broadly beyond that. So tonight's program is about blood cancers. It's an area where we have a major research interest and where research has driven really big changes in investigation, diagnosis and management, such that what were diseases with almost universal terrible outcomes 40 or 50 years ago now actually often lead to really good news stories, and you'll hear those stories tonight where research of advances have led to good cures for cancer, for blood cancers. Of course, it's still a major problem and a major cause of death in Australia, and so there's a lot more research that's needed to be done on it. I'd like to also thank a few people who've actually contributed a lot to our blood cancer research program, and in particular I'd like to thank Bill Petch and Bev Morello, who come from Leukaemia Foundation and who've been major partners of Diamantina Institute in our blood cancer program, and in particular they fund a research chair in blood cancers that's held by Mihir Gandhi, who's going to be one of the speakers tonight. So thank you very much to the Leukaemia Foundation. I'd also like to thank Hardy Brothers, the jewellery company, who have funded a PhD studentship for our blood cancer research program. And so that's going to result in the training of a new researcher who will have a career in blood cancer research and hopefully bring back lots of rewards to patients and by improved treatments in the disease. So actually, that's the end of my thank yous, and what I'm going to do now is hand over to Sophie Formica, who's the MC for the evening, to introduce the speakers and start the evening off. Thanks, Sophie.
Thank you so much, Matt. Hi, everybody, and as Matt said, thank you so much for being with us tonight. A warm welcome from me as well. I know that there are some familiar faces in the audience tonight, but the great thing is that many of you are probably visiting us for the very first time. And if my face is vaguely familiar, it's because I do host a show on Channel 7 called The Great South East. But the reason I'm here tonight is that I sit on the University of Queensland Diamantina Development Board, and I do that not because I have I don't have any expertise in the area whatsoever, but like many of you in the audience, I'm interested. I'm interested in what's happening in this field. I'm interested because I like to be able to think that I have some power and some knowledge when I go to a doctor and I can ask some questions and I can be informed. So whether you're here tonight because you have a general or a specific interest, we welcome you and we hope that this is the first of many occasions that you're able to come and visit us and to understand the work that these incredibly intelligent people are doing on our behalf, because the research that they're doing within these 4 walls will not only impact this generation but the generations to come, and they're doing it on a global scale. So it's about breaking down those walls a little bit, because tonight we really want to be able to open that conversation up. The topic is blood cancer, and I'm sure that there'll be lots of really wonderful questions that you'll have to ask of our panellists as we get through the evening. So a little bit of housekeeping from me first. If you're looking for an exit, it's basically back where you came, and there's also one out to the left side as well. The bathrooms are just to the left of the main entrance of the TRI, which is just out back through the foyer. Tonight will be filmed, so make sure that we get your good side. And it's also live streaming on the UQ website. We'd really love you to get involved in the social media messages that we're sending out as well, because that's a wonderful way for us to be able to spread the word of what's going on here. And so to that end, if you do have your phones with you, you're not going to get into trouble for pulling them out. It'd be good if they're on silent, but if you have the interest in tweeting with us tonight, you can jump on to free Wi-Fi. It'll come up on the screen any second now. The passcode is basically just Blood Cancer with a capital B 2015. So that's the free Wi-Fi through the Your Health Future Wi-Fi code. And we also have a hashtag for tweeting tonight, and that is #BeatBloodCancer. So if any of you are avid tweeters, start spreading the message. We'll also be receiving some of those questions that we'll do through the Q&A session tonight through the tweet wall. So if you'd like to be able to send a tweet to us for a question for the panellists later in the evening, you can do that as well. Without further ado, I'll introduce you now to Bill Petch. So Bill is here with us tonight from the Leukaemia Foundation of Queensland as their CEO, and he has a few words for us.
Thanks, Sophie.
Thank you.
Good evening, everyone. It really is a pleasure to be here tonight with our research partner, UQ Diamantina, and I notice there's many of our supporters in the audience, so thank you for coming tonight. One of the reasons why we wanted to be part of tonight is we're actually celebrating the Foundation's 40th anniversary this year. And in fact, the Foundation was founded right here in Brisbane in Queensland. A lot's changed in the time since the Foundation came into being in the 1970s, when I guess blood cancers were, or a diagnosis for blood cancer was almost an idea that you were going to die and what was going to happen then. I guess patients had limited treatment options, they had limited support options. In fact, you found people living in cars out the front of hospitals and people going interstate for treatment. It was in that climate that the Foundation was founded. After 4 decades of investment in research, we fast forward today where patients have much greater options. Survivorship is something that's talked about quite often, and we've made a great deal of advancements. Certainly, many children now are surviving, but with a diagnosis every 46 minutes and with a death every 2 hours, there's a lot more to do. And I think our goal as an organisation is an ambitious one. It's to beat blood cancer. But the thing is, that was the goal that we started with, and it's a goal that we're going to continue to follow through. I think that when you look at some of the things that the Foundation's achieved over the last 40 years, we have made significant headways. We were actually one of the first investors in the cancer research labs down at QIMR, and those labs have seen quite a number of advancements. We're also the first organisation to invest in the bone marrow transplant unit at the Royal Brisbane, and that was recently celebrating its 25th anniversary, and many Queenslanders have benefited from that unit. We also helped to establish the National Tissue Bank, which is again just around the corner in the PA, and we continue to support that because we realise that it's important infrastructure in research and in fighting blood cancers. We also provide first-class accommodation to a whole range of patients and families who have to come to Brisbane or Townsville for treatment. And in fact, we'll be adding to that very shortly with the greens down at the showgrounds, and that's only 900 metres from the Royal Brisbane. So again, providing really vital support to patients and families. I guess our focus on innovation has meant that we've continued to look for new ways to try and get better outcomes for patients and families, and that's one of the reasons why we've invested in the TRI, why we've invested in the role of the chair of blood cancer, which Mahir is part of. Our idea is that we want to look at every opportunity that there is to deliver better outcomes for patients and families. Not just funding the TRI, but we also have just launched the trial enabling program here in Queensland, and something that will be occurring nationally. The idea of that program, and it being an Australian first, is to allow Australian patients to get access to international trials, to get access to new drugs and therapies that would otherwise be unavailable to them at no cost to them. When we look at trials, we don't just think about international trials, we're also looking at local trials. And one of the things that we'll be launching in the next 2 weeks is a phone application that will allow patients and haematologists to get better access and knowledge around what local trials are occurring here in Queensland. So I think, as you can see, just from that brief outline, that we're committed to continued research, committed to continued discovery, and committed, most important, to better outcomes for patients and families. I guess our goal to beat blood cancer is one step closer tonight, and I really thank you for wanting to come along tonight and be part of that, and I hope you find it very informative, so thank you.
Thanks so much, Bill. To our first speaker now, Dr. Andrew Moore. He's a group leader at the University of Queensland Diamantina Institute, a paediatric oncologist at the Lady Cilento Children's Hospital, and director of the Queensland Children's Tumour Bank. Dr. Moore's clinical and research interests are on acute myeloid leukemia, AML. It's an aggressive form of leukemia with poor prognosis. His research focuses on understanding the causes of resistance to therapy and relapse and aims to discover new therapeutic approaches for this devastating disease. Please make Dr. Moore very welcome.
Thanks, Sophie, and it's lovely to be here and see so many people interested to hear about advances in blood cancer research that's going on here in Queensland and particularly here at TR. So I thought it was salient, if we're having a discussion this evening about beating blood cancer, to have just a simple slide on what our blood is all about. In very simple terms, we have a range of blood cells within our blood, and very simply we have three main types of blood cells. We have red blood cells that carry oxygen around our body. We have platelets that plug off little holes if we bump or cut ourselves to stop us bleeding and bruising. And we have a range of white blood cells which in general terms help us fight infection. These are all made in our bone marrow remarkably from one single cell called a hematopoietic stem cell. And this very special cell sits in the bone marrow, has the ability to make all these cells. Very early it makes a decision to make either myeloid cells, characterised by the red blood cells and the granulocytes and platelets, or lymphoid cells to form lymphocytes. So that's sort of our blood 101. All this machinery goes on in the bone marrow. These cells mature and what we call differentiate and then get passed out into the bloodstream to do their job. Importantly, all these cells here have a finite lifespan, do their job, then die and are replaced by new cells. So what are blood cancers? Well, in very broad terms, blood cancer or an abnormality that arises in the bone marrow we refer to as leukemias or pre-malignant conditions. We also see myelodysplastic syndromes, myeloproliferative neoplasms or myeloma. And if the abnormalities and malignant processes occur in cells in lymphoid tissues outside of the bone marrow, so in lymph nodes or in other lymphoid tissues such as the spleen, the skin, the gut, then they cause lymphomas, and we generally classify these into Hodgkin lymphoma or non-Hodgkin lymphoma. And we'll touch on these further later on. So we're getting to leukemia. So my area of interest, particularly in childhood leukemias, how do the leukemias arise? Well, very simply, it only takes one cell. We call this a leukemic blast cell, and it can generally arise either on this side of the developmental pathway and become what we call myeloid leukemia, or if it occurs over on this side, then it goes on to form lymphoid leukemia. And very critically, these cells acquire abnormalities, molecular and genetic events within that cell that change its properties. Very importantly, these cells lose the ability to what we call differentiate and become a normal functioning cell, and they gain the ability to self-replicate and survive. So these cells don't die, they also don't go on to perform normal function. One cell becomes two, two becomes four, four becomes eight, and eventually we crowd out the bone marrow at the expense of all these normal progenitor cells. So by the time these patients present with their bone marrow full of leukemia, we have a reduction in the number of normal blood cells in our blood. So low platelets, low red blood cells, patients are tired, pale, and low white blood cells. And eventually some of these leukemia cells spill out into the blood, and we can pick those up on a blood test, as well as having low normal blood counts, and we have a high suspicion that this patient's got leukemia. And we do a bone marrow aspirate to confirm that. So that's leukemia 101. Much more information on all types of blood cancer can be found on the Leukaemia Foundation Queensland website, and I really do encourage you to visit the website. It's a fantastic resource provided by the Leukaemia Foundation, and the address is there. So I'd just like to talk a bit about childhood leukemias, and it's very much the success story when it comes to leukemia treatment, but it's very much an incomplete story. And it's really been achieved through clinical trial research and an increased understanding of the biology of leukemias. This is a slide of successive trials at St Jude Children's Research Hospital in Memphis, but this is mirrored across the world in international clinical trials of childhood ALL, or acute lymphoblastic leukemia. It's our most common form of childhood leukemia. We would see about one new patient, unfortunately, every week here in Queensland. They all come to Brisbane for treatment, and many of those families rely heavily upon the support provided by the Leukaemia Foundation. We can see that through successive clinical trials, each trial building on the success of the previous trial and asking the question, what worked, how can we make it better? we can see that the survival rate for childhood acute lymphoblastic leukemia is improved from 11% in the 60s up to over 90% with current therapies. And these patients are cured. And I use that word intently because these patients, their leukemia is gone, it does not relapse. However, and as I said, this is all achieved through clinical trials. This particular trial that was published in 1971 is beautifully written, and it really speaks to what we've achieved. This trial very simply asks what happens if we give more intensive chemotherapy, in this case if we double the dose of a drug called methotrexate. And what they found is that patients had a longer duration of remission. It's a very elegant paper that finishes with a very salient comment that childhood lymphocytic, we now call it lymphoblastic leukemia, can no longer be considered incurable, and palliation is no longer a justifiable approach. And they were making these rather dramatic claims on a survival rate of 11%. At the time in the 60s, it was entirely appropriate to give these children a red blood cell transfusion, make them feel better, and send them home. So this cure rate for childhood leukemia comes with a cost. We use very intensive chemotherapy. This is a slide for childhood cancer in general, but you can see that all these patients have a substantially higher risk of long-term health problems as they grow older in relation to their siblings. 15-fold higher rates of cardiovascular disease, congestive heart failure, strokes, 8-10 times more likely than their siblings. Some of this data is improved now, of course, but what I'm speaking to here is the fact that we're using quite conventional chemotherapy to achieve this cure, and it does come at a cost. So what are we doing clinically? At the Children's Hospital, we're a member of the Children's Oncology Group, which is the largest collaborative trials group for childhood oncology, over 200 hospitals in North America, Australia, New Zealand. And we're proud to say that we're in the top 10 enrolling centres for the Children's Oncology Group. We see it very much standard of care to enrol children on a clinical trial. This is our current standard ALL therapy trial. And what I'm wanting to highlight here is that because our cure rates are over 90% for standard risk patients, what we're now doing through randomised clinical trials is trying to back off therapy and asking the question, can we maintain this better than 90% survival with less therapy? But to do this, you've got to prove yourself to be what we call a good player. You have to have good, favourable disease features and a perfect response to treatment. And it would have been unheard of, as recently as 10 years ago, to try and cure this disease without anthracyclines, without cyclophosphamide. So really no impact on fertility, no risk of long-term heart effects, and significantly less vincristine and steroids, which the parents will tell you is a substantial improvement. So that's what we're doing on a clinical front for ALL. For AML, my particular area of interest, it's a completely different story. This is a disease predominantly of older adults. You can see it exponentially increases over the age of 60. Very aggressive disease, requires intensive chemotherapy, often bone marrow transplantation, and has poor outcomes, which is why I'm committed to research to improve that. We can see for children, unlike ALL, we're only curing 60% of these children. It really has plateaued off in recent decade. Similarly, for young adults, it's worse. Great improvements, but it's still only 50% of the adults under the age of 60 will be long-term survivors. And for the majority of these patients over the 60 years of age, it's an absolutely awful disease, and primarily because they can't tolerate intensive chemotherapy. What we have been able to do is really because of better supportive care and being able to deliver more intensive chemotherapy to push up these survival rates. But as you can see, it's plateaued. And so relapse remains the biggest challenge in AML, and that's what we need to do something about. So our research here at Diamantina, what we're doing is we're using cutting-edge technologies, including genomics, to understand why these patients relapse despite appearing to be in remission. And we want to develop new ways of detecting traces of disease that we didn't know of before, and also harness the genomic information that we're getting to identify new therapeutic targets to improve outcomes. As an example, we see here, this is what we call a CIRCOS plot, where this is a whole genome sequence data. So a patient's leukemia cell, we've looked very deeply, all the genes are surrounded around here. And we can see at diagnosis this patient had a number of rearrangements between the chromosomes within that leukemia cell, which carried the genetic information. There's a rearrangement between chromosomes 10 and 11, and we detected this, or the pathology lab detected this by routine testing, we know that. However, it also detected a lot of other abnormalities that we wouldn't detect on our routine testing, include other rearrangements between 9 and 15, 1, 11, 1 and 10 here. Importantly, at remission, this patient, the 10-11 translocation, as we call it, when two chromosomes are joined, has gone, And this is what our pathology report for this particular patient reported. The patient appears to be in remission, that 1011 translocation is gone. But by looking deeply with genomics, retrospectively, in going back to this patient's samples, some of these abnormalities that were there at diagnosis, this 915 was still there, the 111 was still there, but worryingly, there's a new abnormality emerged in what we thought was a remission sample. And sadly, this patient went on to relapse, but the point of this slide, these are on samples that we've analysed retrospectively, is the power of genomics to tell us a lot more about what's going on inside a patient's leukemia cell, including, importantly, at a time point where we think the patient's doing well and they're in remission. So our goal is to try and understand what's going on in remission, and can we predict which patients need more intensive therapy, is there a novel therapy to keep them in remission. So a lot of this is made possible on the paediatric front by the Queensland Children's Tumour Bank, which I lead, that's based here at Diamantina as well as the Children's Hospital. And we are very proud to say that we collect and store blood and bone marrow from almost every single child and adolescent who's diagnosed with leukaemia in Queensland. As I said, they all come to Brisbane. We collaborate widely with local, national and international groups to facilitate cutting-edge research. Our focus is on AML, but we work with groups around the world who have other areas of interest. And it really has also, on a number of occasions of late, facilitated additional workup for patients where things aren't going to plan, and we have samples in real time. We have on occasion been able to work those patients up further to offer new therapies. And that's something that we would really like to do more of in the future. So that's our program in a nutshell, and as I said, there's a lot of work to be done, but we hope to harness the power of genomic medicine, which we really can do here at Diamantina, to understand more about acute myeloid leukemia in particular and really offer some improved outcomes. So thank you.
Thanks, Andy. We're going to keep it going, so we'll get some more time, hopefully, for your questions a little bit later. I'll introduce to you now Professor Mihir Gandhi, who is Head of Leukaemia and Lymphoma Services, Deputy Director of Haematology at the Princess Alexandra Hospital. Sorry, I'm getting everybody confused now. The Leukaemia Foundation Queensland Chair in Blood Cancer Research at the University of Queensland Diamantina Institute, Senior Staff Specialist and Department of Haematology at the PA Hospital. Professor Gandhi is also established as an international reputation studying immunity and identification of novel biomarkers in lymphoma. His research aims to understand the basis of lymphoma, to devise new treatment which are less toxic and more effective, and to establish new biomarkers to help determine the most effective treatment strategies, to help monitor response and relapse, and to help us understand the development of lymphomas. Professor Gandhi. It's getting you in.
Thank you, Sophie. That was a very generous introduction, and good evening to all of you. Okay, blood cancer and immunotherapy. A very corny way of talking about this is actually to rename this talk "Using Your Immune System to Fight the Enemy Within." But I think it's also a very apt description, because immunotherapy is a very, very hot topic at the moment, and the reason why it is so exciting is because we're getting real results with patients. So what I want to do tonight is just talk about us as a blood cancer community and take a step back so that we, patients, carers, their loved ones, clinicians, nurses, and also research scientists can just look at where we are, where we're going, and what the challenges are in the future. So to understand that, we need to understand some Immunology 101. I think we're in exactly the right place to do that, because so many pioneering investigations have occurred here in Queensland. In 1996, Peter Doherty won the Nobel Prize for his investigations and his pioneering discoveries in telling us how T cells, which are one of the immune cells, can recognize viral infected cells. And viruses are actually a really good and logical way to start, because we have evolved and our immune systems have evolved so that we have a defense system against viruses. So what Peter recognized was that viruses transform cells, and these cells are recognized by the immune system and are then eradicated. And that was taken even further by our very own Ian Fraser, who works in this building. So he looked at a virus and produced a vaccine which actually prevents a form of cancer, not a blood cancer, prevents cervical cancer, but he was using the same principles. In cancer, what we have is a normal white blood cell which becomes transformed, in this case not by a virus, but actually by a genetic mutation. And when that happens, a transformed white blood cell, which is now cancerous, presents these cancer proteins or antigens so that they can be recognized by the immune system. So we have natural killer cells, we have T cells, and we have B cells which produce antibodies, and these are activated, they're expanded, and they're excited by the tumor cells so that they can eradicate them. Which is all fine and dandy, but life's not actually that simple, is it? Because what we normally have is a situation in which the blood cancer cells, which are extremely smart, can hide these tumor antigens so that they can't be detected. And without that, we have no immune system activation. And we call this the immunological secret handshake. It's not all bad, though, because we know that we can actually trick the immune system and readdress that balance. In fact, we've known for quite a while. We've known for so long, in fact, that in this picture, I actually had no grey hair. So here we have Susanna Scott, and she doesn't mind being named. She actually presented with a very rare form of lymphoma, a brain lymphoma. In fact, it was so rare, it was a rare form of a brain lymphoma that was caused by a virus. So we have a vaccine here, and this vaccine was used to treat Susanna when she was actually unconscious and she was having seizures. So Susanna had failed chemotherapy, she had failed radiotherapy. But we gave her one injection of this, and on that day she began to wake up. We gave her 4 injections of this, and the tumor, which we can see here in this brain scan as the white, melted away. What we see here is actually brain scarring. That photograph was taken 10 years ago, and she's still with us today and has had no other treatment whatsoever. Well, not everyone's actually like that. Not only do, obviously, most people don't have a rare form of a rare kind of brain cancer, but actually when we do have patients like that, the reality is they haven't all actually responded as spectacularly as Susan has. So what I would say with Susan is that she was a proof of concept that immunotherapy can work, but it doesn't always work. We've got to learn what's going right, what's going wrong, and try and fix it. So researchers in Munich, and also researchers in America at the University of Pennsylvania, using very, very separate techniques, but coming out with essentially the same answer, have mobilized T cells so that they can eradicate cancers, but what they are doing actually eradicates a great proportion of patients rather than just very specialized boutique cases such as Susanna Scott. And some of the results they're getting are quite spectacular, particularly in acute lymphoblastic leukemia, which is a fairly rare form of leukemia. But interestingly, if you use their techniques in other forms of cancer, such as certain forms of lymphoma, the results are much less spectacular. And also, they're actually getting failures in terms of certain technical problems. So what that is telling us is you actually need to use different forms of immunotherapy in order to treat different kinds of blood cancers. And there are a great many forms of blood cancers. So how can we use different forms of the immune system? Well, here we have NK cells, which is a type of cell that my laboratory has become very interested in the last 2 years, which is a shame because they're actually very complicated to work with. They're complicated because they have a great array of receptors on the surface, and some of these receptors actually inhibit NK cell function because when they engage the blood cancer cell target, they are prevented from releasing their payload. Alternatively, when an activation receptor meets its target, the payload is released and we have tumor cell death. So really, the activation state of the NK cell depends on the balance of these activation and inhibitory receptors. So what one group have done, and this has now been taken over by a large pharmaceutical company, is to use a particular drug called liraglutide, which is currently in clinical trials for acute myeloid leukemia and myeloma to try and block these inhibitory responses. And that's great, and that also works in the response that we're trying to take. I think it could also work synergistically with liraglutide, because what we have identified is a particular molecular pathway, a pathway that seems to be the key master regulator in what NK cells do in destroying blood cancers. And if we activate this particular pathway, we get activation, which we see here in a stepwise manner, which destroys lymphoma, myeloma, and leukemia. And these are results we're extremely excited about, but they're still at the test tube level. But there are other ways that are a bit more advanced, and here I'm talking about other work that's being conducted within the Diamantina Institute by my colleague Stephen Matarola, who's particularly interested in lymphoma and myeloma and producing blood cancer cell vaccines. So in this scenario, we have a patient with myeloma who has his tumor cells harvested by a biopsy, which are immediately whisked towards his laboratory, where you can add molecules and irradiation to perform an NK T-cell vaccine. If you add this vaccine back to patients, the idea is that you will stimulate their immune cells, their NK cells and their T cells, and hopefully that will eradicate blood cancers. Well, he's used this in the laboratory in experimental mice. So here the mice have blood cancer, which you can see by the blue and the red, and with just a single infusion of the vaccine, he's eradicated the blood cancer. It's really very exciting work. But there's more exciting work taking place in the building as well, and this is work of Fiona Simpson. So later, Paula will be talking about a major advance in immunotherapy, which are monoclonal antibodies which can attack a variety of different cancers, particularly certain leukemias and lymphomas. Fiona's work is trying to take these antibodies and make them work better. So they already work fairly well because they can recognize the tumor antigens, but one of the ways in which these tumor cells have developed a secret handshake is they have caused the tumor antigen to become dispersed. So that you can see fit between the antibody and the antigen is not that good. It works well enough, but it's not as potent a signal as we'd really like to cause tumor death and destruction. But what she has developed is a range of drugs called dynamin blockers. And if we add these blockers, what we're getting is clustering of these proteins. And now we have a perfect fit between the antigen and the antibody. And that causes an extremely potent response, and then we get destruction and enhanced blood cancer tumor cell death. And then we come to the blockbuster drugs. These are drugs that are already being produced for certain other cancers and seem to be very effective and are now showing really spectacular results, absolutely groundbreaking results in various forms of blood cancer. Opdivo is a particular drug made by Bristol Myers Squibb. And what they showed recently was some very interesting results in Hodgkin lymphoma, the kind of cancer Delta Goodrum had. And as she responded to conventional therapy, which is chemotherapy, in patients who don't respond to that, they go on to have a bone marrow transplant. If they don't respond to that, they receive another drug if they can get it, called brentuximab. Most of these patients here had actually failed chemotherapy, bone marrow transplantation, and brentuximab. So they were receiving Opdivo at the fourth line of therapy. Each bar represents a different patient, and each bar in its length represents the extent to which the tumor shrank. And in many of these cases, we had quite profound tumor shrinkage to receiving Opdivo alone, so no other therapies were given. And this is really important because we're getting very profound reductions. But the way immunotherapy works is completely different to other forms of conventional therapy, like chemotherapy, like radiation, like surgery. So they can actually be given at the same time as these conventional therapies, so we can get even more enhanced death and destruction of blood cancer cells. And that's great, but there is a problem. You see, if we give immunotherapies, drugs such as lenalidomide or CTLA-19, which improve T-cell and NK cell function Or if we give these blockade therapies I've previously talked about, such as nivolumab, there is a cost, and it's a financial cost. And the problem there is it's going to be very difficult as these drugs go through the translational pipeline and show efficacy in patients for governments to actually agree to fund them. And the reason is, if you talk about one of my pet favorite diseases, diffuse large B-cell lymphoma, which is the most common and aggressive lymphoma that we see in adults, we're already spending a lot of money. The conventional therapy is something called R-CHOP. R-CHOP in Australia costs over 50 million Australian dollars for the 1,500 or so patients that will present every year. So if you add something like Opdivo, you're talking about maybe $250 million per year. It's unlikely that a government will agree to fund that. But if you can say, well, we have a test, and that test can identify which patients will do badly to R-CHOP, which patients will do well to R-CHOP, and which patients will not only do badly to R-CHOP, but will do well with a new novel immunotherapy agent, I think you can make a very clear rationale. Why would you want to not give a patient R-CHOP if they're going to respond to it, particularly since it's tried, it's tested, we know how it works. But I think if patients are going to do badly, then by giving them R-CHOP, you're actually exposing them to unnecessary toxicity, and you're actually probably making other therapies that you might give down the line less likely to work. So a single test would be really helpful. And this has really been a labor of love. It involves a number of people in the audience, and it's involved 6 years of basically blood, sweat, and toil, where we've tried to devise a new test. A test that tells us something about cancer biology, but also a test that tells us something about how the immune effectors like NK cells and T cells can be quantified within the diseased lymph node, but also tells us some way in which we can quantify all in one test these horrible checkpoint cells. And we call this the immunobiological score. And it's great because we've identified 60% of patients who will do very, very well indeed with just the conventional R-CHOP therapy. So here, this OS stands for overall survival. At 4 years, more than 90% of patients in Group A and Group B will be expected to be alive and disease-free with R-CHOP. So clearly these patients should stay on conventional therapy, and I think that will please licensors and funders and health insurers very much. But now we have identified 40% of patients who will have significantly inferior outcomes. In fact, we have Group D, where at 4 years, the overall survival in this cohort, which is overall about 20% of patients, only about a third of those will be alive at 4 years. I think you can very clearly make a rationale that this is the patient cohort that we should be treating with more novel therapies. So the remaining challenges, well, I have talked about the need to select the right form of immunotherapy for the right kind of blood cancer, because there isn't one size that fits all. And we need to integrate these immunotherapies, which work quite distinctly from other conventional therapies, so that we get an enhanced effect. I haven't talked about side effects. I'm happy to talk about that at a later time. I've concentrated mainly on improving efficacy by combining different elements of the immune system, and then, of course, some of the financial challenges that we have in trying to get these drugs into clinics so that our patients can access them. But there is also the cost of research, because discoveries cost dollars. And this is something we need help with in terms of philanthropy and government support. And finally, I'd just like to thank you all very much for listening. Thank you.
Thanks, Professor Gandhi. So much information to digest, and we'll just give you a little bit more now. I tried to introduce Associate Professor before, and this time this is all about her. She is the head of Leukaemia and Lymphoma Services, the Deputy Director of Haematology at the Princess Alexandra Hospital. Associate Professor Malton has extensive experience in clinical research. She was the founding chair of the Australasian Leukaemia and Lymphoma Group, Laboratory Science Committee, and has established and continues to direct the ALLG Tissue Bank. Her other professional roles include medical advisor and board member of the Leukaemia Foundation. She's a member of the government and college advisory committees and several blood cancer drug advisory boards. She does all of that while maintaining a very busy clinical practice as well. Please make Associate Professor Paula Martin welcome.
Thank you very much, Sophie, for that very warm introduction, and thank you to the organisers for the opportunity to participate tonight, and may I add my warm welcome to everybody who's here. I'm going to focus my talk on just one of the blood cancers in which there's been a lot of very exciting developments in recent years, and that is chronic lymphocytic leukemia, or CLL for short. Now, Dr. Moore introduced us to our blood, and I just want to point out that CLL derives from this mature cell all the way down here in the hierarchy of blood cell development, known as the B lymphocyte. Now, this cell resides in our bone marrow, it circulates in our blood, and it's also the main cell in our lymph nodes, and a very important component of our immune system. Now, CLL is actually the most common of the adult leukemias. Whilst it's largely incurable, almost half of the patients diagnosed with CLL will never require treatment for it. It can be a very indolent disorder, and patients will go on to die of unrelated illness. But for the remaining patients, disease control can be very difficult as years progress. And in fact, many of those patients, sadly, will ultimately succumb to resistant CLL. So some of the progress that I'm going to tell you about tonight is very, very welcome news and giving new hope to some of those CLL sufferers who are in desperate need of new therapies. Now, it's important to remember that CLL is in fact a disease of the older age groups. More than half of the patients are diagnosed above the age of 70, and a significant number above 80 here in purple. Now, a normal bone marrow looks like this, where we have the blood-forming cells here in purple and pink interspersed between these white fat spaces in amongst the bony elements of the bone marrow. But in CLL, the bone marrow becomes overrun with these mature B lymphocytes, and you can see replaces those normal fat cells and many of the normal blood-forming elements as well. And indeed, this accumulation of B lymphocytes also occurs in the lymph nodes, which can become very enlarged in patients suffering with CLL. So when we look down the microscope, instead of seeing normal blood with an occasional lymphocyte and other types of white blood cells, we see an accumulation of these CLL cells that dominate the blood picture. Now tonight, I want to take one of these CLL cells and imagine that we can delve inside the cell and understand what are some of the processes occurring in this cell, what is giving rise to this disease, what makes the cell unique, and how can we target it for CLL patients. Now, this is a very complex slide, but over many, many years of painstaking research that's taken place all over the globe, scientists have been able to piece together some of the puzzle of the CLL cell. Now, this blue wall represents the surface of that cell, the surface membrane, and you'll see that there are some molecules that sit on the surface and within the cell membrane. Inside the cell, beyond that, there's this complex array of proteins that are undergoing interactions in a cascade fashion that ultimately determine the behaviour of that cell. Now, because scientists now have insight into some of these processes, they've been able to devise drugs that target very specific aspects of these processes and are able to inhibit or reverse some of them that are causing this disease. And tonight I'm just going to focus on 4 such drugs that have really created a great deal of excitement in the world of CLL therapy. The anti-CD20 antibodies, ABT199, ibrutinib, and idelalisib. Now we'll start with this molecule, the CD20 molecule, in the cell surface membrane. Now, this molecule is unique to B lymphocytes, which makes it a very ideal target because other cells won't be affected by therapies that target that molecule. So antibodies have been developed to the CD20 molecule. And Maher mentioned that these monoclonal antibodies have really revolutionised the treatment of many of our blood cancers. Rituximab was the first breakthrough antibody and really the first immunotherapy in CLL. Rituximab, the antibody, attaches to the CD20 molecules on the surface of the cell and through a series of mechanisms causes the cell to undergo self-destruction or process we refer to as apoptosis. Now, in a very important global clinical trial, which PA patients were able to participate in, this drug, rituximab, the antibody, was added to standard chemotherapy, and it was proven in this trial that survival for those patients who received the antibody as well as chemotherapy was much more prolonged than patients who received the chemotherapy alone before their disease progressed. 57 months versus 33. So this became the new standard. Chemoimmunotherapy was the new standard for CLL. But more recently, those antibodies have been re-engineered to improve their capacity to kill blood cancer cells with the CD20 molecule on the surface, both by direct mechanisms at the attachment point and by indirect mechanisms by harnessing some of the elements of the patient's own immune system. And so this new re-engineered antibody has been put into subsequent trials, and in this particular trial, which was conducted in elderly, frail patients with CLL who were receiving a very mild chemotherapy called chlorambucil, the new monoclonal antibody, GA101, clearly provided more prolonged disease control than the patients achieved who received rituximab with their chlorambucil therapy. And this kind of exciting result with a new improved antibody therapy has now led to the recent approval of this agent for use in that scenario in CLL patients. Now, the second mechanism I want to highlight tonight is here in the red circle. Now, this is a finely tuned process involving many different proteins that ultimately leads to a cell's self-destruction when its finite time span, as Dr. Moore mentioned, or its biological use-by date, if you like, is up. So cells have to undergo self-destruction and be removed from circulation when their time is up. But in CLL, this process is imbalanced, it's not finely tuned, and in fact cells have an abnormally prolonged life and they accumulate because of this abnormally long survival. So this drug, ABT199, is targeting this process and targets one of the proteins which is causing this blockade of self-destruction or apoptosis, and it blocks that inhibition of apoptosis and restores the cell's ability to self-destruct and be removed from circulation. So with this understanding, this agent was put into clinical trials, and the first reports of this early phase trial with ABT199, which was reported by Australian investigators who were instrumental in understanding that pathway, shows this incredible response. Professor Gandhi introduced you to this waterfall plot concept whereby each bar represents a patient and the percentage reduction down from the zero line represents the shrinkage in each patient's tumour volume. And you can see from 100% shrinkage, and this is the 50% line along here, remarkable responses. Only 3 didn't respond in what was, and always is in early phase trials, a very heavily resistant group of patients who'd really run out of other treatment options. So this was indeed very exciting news. And since that time, the ABT199 molecule has been combined with monoclonal antibody therapy because they are targeting different mechanisms of action. And in fact, the responses in lymph nodes, as well as the bone marrow infiltrates, have been even deeper and more impressive. So this has certainly been hailed as another breakthrough agent in the therapy of CLL. Now back to our cell. This green Y-shaped molecule sitting again on the surface is known as the B-cell receptor, and it's a very important receptor that receives signals from within the body, for example, when fighting an infection, that is then transmitted through this incredibly complex array of proteins through to the nucleus and ultimately determines the cell's behaviour. Now, by understanding this pathway, scientists have been able to target one of the very key enzymes within that pathway that transmit the signal to the nucleus and block it with a drug called ibrutinib, and thereby stop the signal getting to the nucleus to proliferate and survive, which is good in the setting of fighting an infection. But in CLL, this signal is abnormally stimulated and occurs over and over again, giving rise to abnormal proliferation and survival of CLL cells. So once again, from the laboratory to the clinic, clinical trials were conducted. And here in an early phase trial, again in heavily pretreated patients, often desperate for new treatments, incredible responses were seen with vast amounts of tumour reduction in those patients. If one compares the response duration of patients receiving ibrutinib compared to an anti-CD20 monoclonal antibody alone, again in a heavily resistant patient population, you can see that the duration of disease control is far superior. And more recently, this drug ibrutinib has been added to a chemoimmunotherapy regimen, and again one can see that patients who receive the new agent with the standard chemoimmunotherapy have much more prolonged remissions than those who receive just the chemoimmunotherapy alone. So again, another breakthrough agent in CLL through understanding mechanisms of disease and bringing new targets to the clinic. Finally, another drug that is really revolutionising the way we treat CLL, again targets part of this BCR signalling pathway, the B-cell receptor signalling pathway, by inhibiting this enzyme, PI3 kinase, with this drug, idelalisib. Again, idelalisib has been put into early phase clinical trials, and we're getting very used to seeing these waterfall plots now, whereby astonishing results were found in evaluable patients who'd been heavily pretreated and were very resistant. In fact, here is one such patient who participated in this trial, and you can see, despite having been resistant to 5 prior lines of therapy, there was a normalisation of her very enlarged lymph nodes here in the neck and, of course, elsewhere in the body. Once again, combining these therapies is possible because of the different mechanisms they utilise, and you can see that idelalisib with monoclonal antibody has superior outcomes for patients than using antibody alone. Now, all of these drugs that I've mentioned, the 4 of them, are in ongoing clinical development, and we're very fortunate here at PA to be able to provide for our CLL patients quite an array of clinical trials that utilise these drugs, now in combinations, trying to work out which is the best combination, how do we refine the usage of these drugs, and compare them to some of the standard treatments so that we're getting the most benefit from these new drugs for our patients. So these are all ongoing trials here in our clinic. So in giving you this brief update of what's new in CLL therapies, I hope that I've emphasised the incredible importance of both the basic laboratory research, understanding disease mechanisms such as goes on here in the TRI at UQ Di, as well as the clinical trials work in the hospitals. And facilitating the communication between these 2 arms of research is vital infrastructure such as our tissue bank that Bill mentioned earlier, which is a national facility that systematically collects and stores patient material for use in medical research. And without patient material, none of these breakthroughs could have been possible. So in closing, I too want to acknowledge my great gratitude to the Leukaemia Foundation, which has had the vision and the commitment to fund and support all three of these pillars of research: grants to the researchers in the laboratory, funding for the tissue bank to provide patient samples and material, and clinical trials funding through the new initiative, the Trials Enabling Program, that will facilitate more Australian patients being able to access new treatments in our blood cancer disorders. So I'll stop there, and thank you very much for your kind attention.
Thanks, Paula. It was lovely. Again, just a little bit of information to digest. And it's wonderful to hear about all of this amazing research and these drugs and the trials. But of course, there are some who have more intimate knowledge than others. And, you know, we mentioned earlier that 31 Australians are diagnosed each week with a form of blood cancer. And blood cancers are now the third largest cause of cancer deaths in Australia. Our next speaker tonight was a very fit and healthy young man in the prime of his life who faced a totally unexpected and life-changing diagnosis with a rare blood cancer, acute promyelocytic leukemia. I'll just stick to APML. It was just a few years ago, and he's very brave tonight and wants to share his story, so please make welcome Jeremy Morris. You might have to use your big voice because his batteries have just fallen out of his microphone.
How's that?
That's all right. I'm used to these. In fact, I've normally got one. Jeremy, thank you so much for coming in and sharing your story with us tonight. And I know that there'd be a lot of people who are in the audience tonight who have their own, blood cancer story, perhaps first or second hand. When you hear about the numbers, obviously it's got to be somebody. And in this case, you were very surprised to find out that it was you. Tell us about your diagnosis just a few years ago.
Yeah, sure. So my cancer journey started in 2012, in September. It was a pretty normal time in my life, nothing much going on. I didn't really have a great deal of symptoms at the time, apart from just some bruising appearing randomly on my body. So at first, we didn't give it a lot of thought, but then over time, as they became more numerous, we were a little more concerned. So my wife requested that I go and get a blood test. So I asked one of the doctors at work to write me a blood test, and later that afternoon, I was on my way up to the hospital and spent about 6 weeks in the PA hospital after being diagnosed with APML. And following on from that time, thankfully, we were able to knock it into remission, and I was able to go home. So I returned on and off for a few months, getting outpatient chemo, and was then on oral medication for about 2 years, which finished in Easter time this year.
You mentioned, obviously, you were married at the time, and also a young dad. How did that impact you, in terms of the emotion and the impact that it had on family life to go through that?
Yeah, well, obviously it was quite profound. Beth was only about 12 months old at the time, so we'd gone from being married, having a child, and planning our future together to everything being turned upside down, basically. I think I was at ease a little bit because most of the doctors that I'd seen had told me that it was very treatable, and that had quite a high likelihood of going into remission and hopefully staying there. So that helped to ease the blow a little bit, but certainly the change of routine, loss of the roles that I had as a father and a husband, and in my workplace and everywhere else in my life was a big change. But like I said, thankfully I had a lot of hope for the future because of research that's being done and the treatments that have been successful so far.
What was that like for you, having that access to that information, having the Leukaemia Foundation directly? How did that relationship impact you?
Yeah, well, it was obviously, like I said, it really helped to ease receiving that news, and I think that full credit to the doctors for caring for me appropriately and really giving me that hope for the future. I don't think it would have been quite the same had I been diagnosed with a different cancer and knowing a little more about it, about the chances of survival being a lot less. So I'm not sure if that answered the question, but.
Like most men, I guess, when you found out then that you were okay, you decided that the first thing you'd do is test yourself physically after treatment. Yep. Tell us about then deciding to to join the 55k walk?
Yeah, so we heard about the 55 for 5 shortly after I returned to work, and yeah, it was just a good opportunity to try and raise some funds for the Leukaemia Foundation for the great work that they do. I've learnt a lot more tonight about the work that they do. I didn't realise that the reach stretched as far as it did.
Were you already an avid hiker before that? Because 55 kilometres is a long way.
Yeah, well, it's done really well. They organise it well, spread out over 2 days, and there's a lot of support along the way. I did enjoy hiking before. I enjoy being in the outdoors as much as I can. So that sort of combined a new love of an interest for supporting the foundation, and also getting into the outdoors, a chance to test myself after having the treatment and to see whether or not I was still physically capable of something like that. So,
yeah, we've talked tonight about cancers, blood cancers, as they affect the very young through to the elderly, and during this journey that you had yourself, you then had another blow in that while a lot of children survive a blood cancer, you had somebody very close to you not be so fortunate. How did that affect you?
yeah, well, obviously it was terrible. Young Jackson was a good friend of my daughter's. He went to her kindy, and my wife works at the centre as well, and so he was a very popular little boy, and I actually found out the day before the 55 for 5 last year that he'd passed away. We're still waiting on some information from the coroner to determine exactly what it was, but as far as we're aware at this stage, it was leukaemia or leukaemia-related illness. So that was, yeah, obviously very horrible, and to go and to be on the walk with it pouring rain for the entire time, and being there kind of alone with my thoughts and what was going on. It was definitely very difficult, and there's obviously been quite a grieving process involved in that, but it also spurred me on a little bit to say that, remembering what I'd been through and obviously what he would have gone through, and I just had to dedicate that walk to him and push myself on through it, and that really helped me along.
So the next walk is just in 3 weeks' time?
I think so, yeah.
You're looking pretty fit, so you're ready to go?
I feel very fit.
I'm not walking 55k. But tell us a little bit about that, because obviously you're in the process at the moment of doing the fundraising, and getting as many people as possible to support you.
That's right, yeah, just trying to get the word out there as much as possible. Social media is a great help for that. Again, I've managed to raise a little bit over the last couple of years, so I really want to try and at least match what I got last year, and hopefully a little more. So it's just great to see a lot of people getting on board too with the fundraising to try and help the foundation continue the work that they do, because it is really amazing.
And of course, everybody here tonight can jump on board and sponsor you if you feel that they like. The website is easy. It's 55for5.org.au. Yep. We'll find you on the list.
Yeah, just search for me there.
All right, please put your hands together for Jeremy, and thank him for telling us his story. He's going to stay with me. We're going to invite our speakers to come back up onto the stage, so if you have some questions for them. This is a time of the evening. I understand perhaps some of you have to be elsewhere. If you have to leave us, this is probably a point to do it, but I'd love you all to stay for our question and answer session. If I could invite Andy and Paula and Mahir back up to the stage. I'd also mention at this point that this conversation is really very general in nature. We recognise that there might be many members in the audience tonight who have a very personal experience with blood cancer, and that may be a reason that you're here. The questions that we will answer, though, can't be about a specific patient's treatment. As you can appreciate, the panellists aren't across individual medical histories, and it makes them very difficult to address those questions. So we would suggest that if you have specific questions from the information you've received tonight, that you're best to sort of make a note of those and speak to your own specialist about them. But it's certainly wonderful to be able to take perhaps something you didn't know from tonight's conversation. So some of the questions tonight have been submitted by our audience members prior. Others have elected to have questions asked by me this evening. And then, of course, we've got our tweet wall that's going to come up as the conversation continues. So we'll start perhaps with one of the questions from the audience tonight. Is Brad Zeller with us? Brad, he's over in the corner. Fantastic.
You want me to ask a question?
Yes, please, if you'd like to.
Can you hear me? Yeah. I think the the talk given by the professor has probably answered most of my queries about CLL. But I guess my main interest was what clinical improvements have there been in the last 5 to 10 years in terms of patient survivorship of that condition. I think the professor did touch on it, but maybe she'd like to recap.
So specifically for CLL, I think it's one of the headline diseases in which there have been huge advances in the last 5 to 10 years, starting with the monoclonal antibody story that dates back. That initial trial that I mentioned was back in 2008. And really over the last 2 to 3 years, the explosion in the results from the newer agents that I described, really targeting very specific aspects of the abnormalities that have been understood in the CLL disorder. So there's no question that these have been life-saving developments, and the outcome for CLL patients is certainly improved. Now, I don't want to give the misunderstanding that these are curative therapies. These are not. Patients are still showing signs that CLL is still present, but these therapies are able to control disease for much longer periods of time and in settings where we've previously had nothing else that would control the disease. So I think from the point of view of survival, it is definitely prolonged, but we can't yet say that any of these measures are curing patients with CLL to any great extent.
Paul, if you don't mind, I might just keep the spotlight on you for just one more question that comes from Louise Sugar's. And I don't think you specifically talked about the genetic testing for CLL. Her question is there any research being done in regards to genetic testing as 4 siblings have been diagnosed with CLL in the last 5 years?
Right, so that question is specifically about familial CLL and genetic testing for the risk of developing CLL, given that family seems to have a high rate in 4 siblings. And there are certainly cohorts of families that have been identified over the years that do have an increased rate of CLL within them. Mostly, CLL is what we call a sporadic disease. It's not something that's inherited or familial, and there's no specific genetic test, unlike BRCA for breast cancer or other genetic tests, that we can do that identifies any particular risk for CLL. However, there is keen interest and registries both in the UK and in Australia of collecting these cohorts, and with technologies that have evolved so rapidly over recent years, it's likely that underlying genetic mechanisms for that rare group that do seem to have a familial form of CLL will be uncovered. The other aspect, if I may, to genetic testing within CLL is for those patients who have ordinary sporadic CLL, the type of genomic testing and genetic testing that Dr. Moore spoke about in the AML setting is also being applied to this disease. And we're getting much better at risk stratifying patients and finding out those who are unlikely to ever progress and may never need treatment versus those who are likely to progress very rapidly and have a very aggressive form of CLL. It's a very heterogeneous disease, and that type of genetic testing is helping us tease out those patients and direct them to appropriate therapies more readily.
Andy, there's one that's come up on the tweet wall that's probably best for you from somebody who has a very amusing Twitter handle. Tim Casaurus Rex. What are the ethical implications of trialling cancer drugs on children? Does this make it harder to develop treatments?
That's a fantastic question. Not a very short answer, I have to say, but I'll give it a shot. I guess the challenge that we have in childhood leukemias is that they're relatively rare. I think one of the traditional paradigm for testing new drugs in children is that we have to show that they're safe and effective in adults before we're prepared to give it to a child. And whilst that's understandable from a drug development framework, a drug company will have spent many years and many millions of dollars developing a drug. They want to make sure that it works and it's safe before giving it to a child. It does hold up that process, and so children lag behind in their access to therapy. So that's one issue. The other issue is that because these leukemias and childhood cancers are relatively rare, we have small patient numbers, and so we collaborate internationally. That creates barriers. So it's not so much a ethical issue, it's more a logistic issue in getting children access to therapies that are really showing fantastic results in adults. But it's the challenge of getting that drug availability in Australia. Companies are trying to license drugs in the United States or Europe. Australia may not be a big market for that drug, and then if you've only got a handful of children who may very well benefit from that drug, it's a challenge in getting access to those trials. So from our point, and also I suppose one of the other ethical issues is because a patient who maybe have very poor prognosis, you don't want to, they should be at home, at school, you don't want to give them an ineffective therapy. And so that's probably the biggest challenge in identifying which patient is going to respond to which drug, but the drug's got to be available, and that's probably the biggest thing.
Jeremy, was that one of the more interesting things for you tonight, having gone through the journey yourself, to hear about these different drugs and how some people respond to some things and not to others? Did you have that sort of experience as well?
Absolutely. I think just to learn that the research is continuing and is actually making so much progress. I think that's been amazing to see.
Yeah. Is Dr. Alex Crandon with us? Yes. We have a question from Dr. Crandon.
What information do we have that might provide some insight into why Hodgkin lymphoma is increasing so rapidly in the population?
Okay, well, what we have are clues, but we don't have a definitive answer. Over the last 20 to 30 years, we've actually had a very marked increase of 4% per year. It's been consistent. That's actually resulted in a doubling in non-Hodgkin lymphoma diagnosis. And we know that it is not due to better diagnosis. It is not due to AIDS, even though there is an increased incidence of AIDS. Increased incidence of non-Hodgkin lymphoma with AIDS. We have some clues from large international collaborations which have told us something about genetics. Now, clearly, we haven't as a population changed our genetics in the last 30 years, but we know that there are certain genes involved in the immune system which are mutated. And these genes actually occur in a large proportion of us. But if they occur in us, we're more likely to develop non-Hodgkin's lymphoma. And I think what that is telling us is there is an environmental cause which is interacting in some people who have a genetic predisposition, and they're more likely to develop lymphoma. And we know that actually by studying large populations. That's the science of epidemiology, because certain parts of the world have greater proportions of certain kinds of lymphomas than others. For example, in Hong Kong, in Japan, and in southern China, but interestingly not in northern China, there is a particular kind of lymphoma called extranodal NK T-cell lymphoma, which is extremely rare in Australia, but is actually very, very common in these parts of the world. And we know that in that particular lymphoma, it is linked to an environmental pathogen, which is a virus. But I think that, again, is an example of what's probably happening in other forms of lymphoma, but we haven't yet identified what those environmental insults are.
It's another one that's popped up on the tweet wall. You mentioned the underlying predispositions for leukemia, but this turns it around to, is the susceptibility to disease in leukemia survivors a consequence of chemotherapy treatment or underlying predisposition? Andy, you talked about that a little bit when you said, it comes at a cost. We might be able to fix this, but then in turn we then have statistics that rise in other areas. Would you be able to extrapolate?
Sure. I guess the majority of patients, we certainly know that certain chemotherapy drugs in high enough doses do cause what we call secondary malignancies. One of AML is a good example of that, where patients can get secondary AML from chemotherapy they've received for other solid organ tumours. So we certainly know that certain types of chemotherapy can cause second cancers, and particularly AML is an example of that. But then there are quite a rare range of what we call
cancer predisposition genes that people can carry where they are at a higher risk of developing their first cancer, and then those patients, yes, are at an increased risk of developing a second or a third type of cancer later in life. But those syndromes are really quite rare, thankfully. They do occur. We do see them from time to time. But thankfully, one of the things is our clinical trial research has shown that because we can tease out which patients are likely to do very, very well, particularly in children, we can reduce their exposure to drugs that we know can cause long-term heart problems, can cause an increased risk of secondary cancers. So clinical trial research and a better understanding of the biology of individual patient diseases allow us to more individualise their therapy and reduce risks like secondary cancers.
Paula, is that your experience as well? Is there more of a sort of holistic approach when it comes to having to target one particular disease and not necessarily expose people to the increased likelihood of others?
Well, in CLL, for example, there is certainly evidence that the disease itself is a risk factor for the development of other tumours, even in the absence of therapy. So clearly there is some underlying susceptibility within those patients who develop CLL to develop other malignancies such as bowel cancer, skin cancers, etc. And that's very clearly been shown. Add into that mix chemotherapies and other treatments, then that risk is heightened even further. So it is certainly one of the long-term aspects of care in patients that one must look at long-term consequences of both the disease and the therapies that have been delivered.
Does anybody have a question from the floor, from the conversations that have been happening tonight, or from... Yes, down here. Okay, there's somebody behind you. I'll let him have the opportunity to, just in case you didn't have your phone to tweet. Yes.
Thank you for the lovely presentation. So I have a question about the cost, which is related to the one of the tweets up there. So my question is, given that the treatment is so expensive, how much of it is really pure profit to the companies making a treatment? Given that the research costs are already sunk, and how much of that profit is then reinvested into research?
It's actually a very interesting question. It's a difficult one to answer. Drug companies, the two biggest costs that they have are research and development and also marketing. With research and development, one of the main reasons that is so expensive is because it's very hit and miss. So for every blockbuster drug, they have countless many others which are actually lying dormant, which don't work. Or they might work, but another drug from another company has come along which is better. And so all that money has been wasted because they know that they're not onto a winner. So that's why it's very expensive. It's difficult to answer your question about how much of it strictly goes back into profit. Certainly what we're seeing are that the drug companies are becoming larger. They're merging more and more because that's a way of keeping down their overheads. And a lot of research now is actually being done by drug companies. I had a meeting with a drug company last week, and they were asking me some very basic questions which clearly related to the fact that they had limitless funds and they could do things that I could only dream of that they could do fairly quickly. So they are, what they're doing increasingly now, are developing models where they are actually partnering with researchers around the world who have particular expertise so that they can actually do their research even more cheaply because they're sort of buying up expertise. How much of that relates to profits, I don't know, but it's certainly a very good way of keeping their costs down.
Professor, if you'd like, wouldn't mind this one too. Will the genomics revolution and personalised medicine lead to more effective clinical outcomes? I guess you touched on that a little bit in your presentation, but when we were speaking before the presentations tonight, we were talking about this, seems to be this pivotal time at the moment in research. We said there really has been an explosion because of immunotherapy and the area of genomics when it comes to, you know, almost all areas of medical research, but certainly for blood cancer.
I mean, I think it's the most exciting time that I've ever seen in blood cancer. And that's across the board, not just immunotherapy. We are seeing truly remarkable, revolutionary responses in patients with leukemia, with myeloma and lymphoma. And a lot of that actually comes down to genomics. It's not that long ago since we actually sequenced the human genome, but what we've done going forward from that is that we've identified a large number of mutations. And within those mutations, we've actually learnt how the immune system can interact and prime various immune cells. But we've also identified a whole range of molecular pathways, and we're now teasing out and dissecting specific components of those molecular pathways so that we can destroy cells. So if we have a molecular pathway that involves 20 different proteins, that's 20 different potential targets. And we can actually use those different therapies to synergize and destroy cells. And we know that to destroy cells, you don't only just destroy maybe a particular pathway within that cell, you destroy blood supply going to those cells. You enhance the immune cells that might also target those cells. You do a whole range of things that all seem to work together. And we can take old therapies and actually work out how they work so that we can only give the most effective components of their therapies. And in that way, we can actually reduce some of the very non-specific broad side effects that we get. So I think it's a really exciting time.
Any other questions from the floor? Just down the front, please. Let's get a microphone to you.
Hi. My question was relating to the immunotherapy that you were speaking about earlier. Try not to relate it too much to myself, but I was just curious because I had, sort of the whole box and dice chemo, radiation and a BMT, because of the concern of relapse. And I guess I was wondering, obviously that's still a concern. How does that, is the chance of, I guess what I'm trying to ask is the chance of relapse with immunotherapy decreased compared to other current treatments?
It depends on the disease, but there is a broad sweeping statement, I think, which is that if you have an immunotherapy that comes from yourself, if it is actually about activating your own immune system, and that is something you're going to have with you for the rest of your life because the immune system has memory. So this is quite different from a drug like rituximab, which is what we call a passive vaccine. It doesn't have immunological memory. It lasts for as long as the antibodies are around in your system, but then your body doesn't produce any more. Whereas if you have a vaccine, or actually bone marrow transplantation, which is an extremely good immunotherapy, then you can produce your own response. And that's important because we know that one of the ways in which cancer actually occurs is that it's actually occurring in all of us at various times in our lives, but these cells are being eradicated. Okay? It's not actually unusual for something to go wrong in the machinery of a cell during its lifetime and potentially becoming cancerous. And we call that a process called immunoediting. But most of us can eradicate that. In patients who've had a cancer and who've had an active form of immunotherapy, they can also eradicate that. So yes, I think in that scenario, you are less likely to relapse.
I'll ask a question on behalf of Sam Richards, who's in the audience. We talked a bit about this lovely idea that globally there seems to be the sharing of information to help, find as many cures for diseases across the board. This one's specifically about swab testing and bone marrow registries. It says, why isn't swab testing to join the bone marrow registry available in Australia as it is in the UK and US? Paula, is that one that you'd like to?
I'm really not sure what the answer to that question is. Perhaps Andrew has some information.
Might have stumped us, Sam.
Again, I think most people who are on a bone marrow registry are probably patients who have had a blood test and been tissue typed, what we call tissue typed, as a potential donor for their sibling, and choose to stay on that registry because they might not have been a match for their sibling and so are there for the greater good. Of course, anyone can join a transplant registry. So that's probably how we have most of our donors on the registry. In terms of
it's really a technical question in terms of a blood test versus a swab to get that tissue typing testing done. I can't answer that question, but...
It may be a resource issue. I'm not sure what has led to the development of those techniques being
Could
used
it just also be
internationally.
a numbers issue, that we haven't got the same numbers that they would have in the UK and the US?
It's possible. It may also be a reliability factor. Certainly the way it's done here, which is the tried and true traditional blood testing and tissue typing, is extremely reliable. We have a very good registry system. It's well funded and well analysed and well resourced. So I don't think I would be disappointed that we're not using an alternative technology that might have been introduced in other nations.
I might finish up with Crystal. Is Crystal Sharwood still in the audience? Would you like to ask your question? Let's get a microphone down to you.
Thank you very much. I actually had a question relative to the gentleman behind me. Would there not be a conflict of interest with the larger pharmaceutical company DSM Biologics now partnering with TRI in the development of drugs, because it doesn't seem to be like we're looking towards a cure, but more long-term treatments?
I'm not sure who that was directed to, but...
Just in general.
Sure.
Yes.
My own take on that is that I don't believe that drug companies are specifically identifying treatments that will not cure patients and will go on to long-term therapies. It's true that many of the developments that have occurred recently, particularly in the field I spoke about, CLL, requires long-term therapy to keep disease under control, and that removal of those therapies leads to progression or relapse of the disease. So that has transpired, but I don't think it was specifically targeted that way. It just so happens that that's what's eventuated. If you take, for example, chronic myeloid leukemia, where the blockbuster drugs came, the targeted therapies for that disease came more than a decade ago, we're now seeing patients who are essentially cured from that and who are coming off what we always thought would be long-term, lifelong therapy and appear to be cured. About half of the patients who come off those targeted therapies are able to stay off and not require ongoing therapy. And certainly drug companies have been funding and instrumental in running the trials of withdrawal of therapy, which I think is to their credit. This all comes back to the issues we've been skirting around here in terms of profit, cost, the commercial imperative that drug companies have to work under. But I don't think I'm cynical enough yet to truly believe that they're seeking to avoid curing patients in order to maintain profits with long-term therapy.
So, Jimena, is it more like the ethical consideration of a drug company being involved in the research?
For a cure, if that's not going to make them money. Do you understand what I mean? And I think a lot of people are thinking this as well. It's been decades and decades with billions of dollars of money going to research. We're not seeing what's happening.
Well, I think it's very important to balance drug company-directed money and research with independent research funding, such as from the NHMRC, from the Leukaemia Foundation, and from other sources that simply fund excellence in research, great ideas, meritorious approaches, rather than a specific outcome-based funding process. And certainly, I think as far as possible, we need to maintain those investigator-initiated ideas that are independently funded, that create the breakthroughs in many instances, rather than specific outcome-directed funding from pharma, which, you're quite right, in some sense may represent a conflict of interest in certain scenarios.
There was also another question about the idea of is there anything that you can do to prevent blood cancer? That was on my list, and it also came through in a tweet. And I'm not sure whether or not there's an answer to that, but it's right there. Is there any way to prevent blood cancer? we can, not smoke and limit our chances of a lung cancer and do things, we had a very interesting discussion about the gut biome and the things that you can do to look after other bits of your body. But can you do that for your blood?
Yeah, I think that's an important question, because often when you tell a patient a diagnosis, that's actually one of the first questions, and I think it somehow relates to personal guilt, that there's something that an individual has done in their life. And there is no guilt. It's actually indiscriminate. Anyone can get a blood cancer, and it's not a lifestyle choice. It's nearly always not an infection. It's nothing that you've acquired in terms of an infection or something that you've passed on. It really is entirely indiscriminate. There are certain things in terms of lifestyle which appear to predispose, but the evidence is not clear-cut. It seems to be, for example, that lymphoma is more, or certain kinds of lymphoma are more likely if you smoke. There is some evidence actually that lymphomas are more likely to occur if you use hair dyes, if you believe that information, and not everyone has been able to reproduce that. In order to convincingly show that something can cause a blood cancer, you actually need a mechanism. You usually need an experimental model, normally an experimental animal, that actually can do that reliably and reproducibly. And we haven't actually found anything convincingly which shows that there is a lifestyle choice which is definitively causing blood cancer. So it's a very, very different story to, for example, lung cancer and smoking.
Jeremy, what was your reaction
to
hearing when you I imagine it wasn't over a phone call. So when what went through your head? Was it a similar sort of thing? Did you just?
I was actually going to say I'm quite happy to hear that it wasn't lifestyle related. Not that I have any reason to. When I initially found out it was actually at work, it was numb silence was sort of my main reaction. But like I said before, I was given the right information about, yes, there's likelihood for effective treatment and a cure there. So I think maybe my experience is perhaps not what the norm would be in working in a medical field as well. I try to remain a little bit objective to what was happening to me. So like I said, it was shocking and frightening at first, but with what I was told, made it a little more bearable. So. But again, that's probably not everyone's experience.
Well, everybody's story is different. I think that's the other thing you take away from this. It seems very much like it's definitely not a one-size-fits-all approach when it comes to blood cancer. One last question, and then we'll let you know from your evening.
Dr. Laura, you just mentioned about CML, that patients can be cured. Yeah, when you say that, does it mean that they have no traces of cancer in the body and they can stop taking that medicine, whatever they are taking? Is that right?
Well, I should perhaps qualify that. This has been done in patients who have been in long-term remission. So within the clinical trials that trialled stopping therapy to see what would happen, and there have been a couple of substantial trials now that have had almost identical results. Those patients were in deep molecular remission, and we have molecular testing now that can identify 1 in a million cells being CML positive or not. If you are negative for 2 years or more, then you were able to enter those trials and come off therapy. And as I said, about half of the patients, a little under that, did not go on to relapse and remain under regular surveillance and appear not to be getting the disease back. Now, whether they are cured lifelong, perhaps I should withdraw that term and say they are in long-term remission off therapy. But obviously that observation will need to go on for a very long time before we can confidently say that disease will never come back. And I think for patients who are not being enrolled in clinical trials, who may be doing that with their private haematologists, it's very important to emphasise that very careful monitoring must go on. We're certainly not at a stage yet where we know who's going to relapse and who